Just all right. Good afternoon, all of you. Thank you, Dr. Chalpati and Dr. Mohan, for giving me a grand introduction. My dear colleagues, friends, and future colleagues, welcome to all of you. It is my proud privilege to share the platform with many stars in prosthodontics. I thank the organizers for giving me this opportunity to participate in this occasion. So I will be speaking on the centric relation update. Now you have heard about maxillary defects and then the mandibular defects. Now this may be putting together without any defects. Now the centric relation, although is simply a relation between the two bony structures with the cartilage in between, in the middle of specific location, it has been a highly debated topic. It's very surprising to see when I tried to check in the Google Scholar for centric relation, I just noticed that nearly 6,54,000 articles have been published on this so far, as shown by Google Scholar alone. Well, then I thought, let me see for the new things. Then the centric relation in 2021, it says there are already 3,130 articles have been published. So you can imagine the amount of work that has been done on this topic of centric relation. It is just the mandible, the condyle, and it is sitting in the glenoid fossa. That is its home position. So my objective is very clear. I'm focused on first and second year postgraduates, and it is revision for the third year postgraduates and the exam. And so it's just a past, present, and future of centric relations. These are a few very interesting articles that I found. I think the postgraduate should take a screenshot if feasible, and they should be able to read these articles or refer these articles without fail. So these are very interesting and they give a lot of evidence-based information to it. Now, why this enormous work on this one position? Because the mandible is supposed to be meant for mastication, right? But its movement is influenced by so many events. You can see whole of the central nervous system is catering to this area, including the all the CNS. I mean, all the central nervous system, all the nerves are being catering to this area one way or the other, either directly or indirectly. So nearly 90% of the CNS is catering to the this area. So you can imagine. So whenever the brain tickles, the mandible moves. Well, then how do we position the jaw during mastication? Now, mastication is a combination of a voluntary and an involuntary movements of the mandible. Now, when we are trying to chew the food, it just starts as an initiation, very conscious. You take the food, you put it in the mouth, and then you start eating. Well, then you don't really focus on how you are eating and all that. It becomes a subconscious act. Here, the sensory and motor actions take over to complete the mastication, and then deglutition also, until we get ready for the next increment of the food. The muscles will elevate the mandible, how much it has to elevate, in what direction it has to move. This is all depends upon the sensory input by all these proprioceptors and the judgment and decisions taken by the centers in the brain. Well, if you are watching TV and then you are eating, everything will be subconscious. You may not be really aware of what is happening. Well, there is something called as an engram. It is the programming. And how does it happen? Because of the movement and what kind of food we are having, and all that sensory input is given by all the sensory areas, and then it will be processed, and then the information given back to the muscles which are moving the mandible. Well, then there is a pattern that is generated by the inputs that are given by the teeth. And this pattern is generated by the at the brainstem, that we call it as a pattern generator. So any disturbance to any of these receptors areas, what we saw, could influence the whole system. That is, that although the temporomandibular joint is very forgiving and adjustable, but still there is a limit for it. Well, this centric relation is just like a home, or a sweet home. Like all of us, we go out and we do all these different functions, and then we come back home and we are very comfortable to be at home. As we just relax over there. The condyle does the same, and the condyle also feels that is the most comfortable position for it to be. That's why we are all doing so much of work just to keep the mandible in position. It's like whenever you have a problem, you hit the home button in your mobiles or the websites and things like that. Well, then why do we have to record the centric relation? Because we need to work on the prosthodontists, we need to work on all these things, and then we want to have the articulator where we are going to mount should work like the patient. That is our major aim when we are thinking about the centric relation recording. All right. Well, then, as through the ages, nearly for 100 years, it has been studied here, and then they have studied on dry skulls to begin with, and then they did the cadaver studies, then they have done the radiographic studies using OPG cephalograms, then they have done the laminographic studies, and then the CBCTs, MRIs, ultrasonics, whatnot, whatever the possible imaging ways are being studied just to understand where the condyle is going to be at its comfortable position. So you can see here 1920 where the McCollum started. So it's exactly more or less 100 years, or you can say 101 year. And then he said by his studies while he is presenting the terminal hinge axis, he said about it as the most rearmost position. And then the grandeur said uppermost position, and then Boucher said it's a most posterior relation. Because all that they used to think at those days is how to put the mandible in a backward position. So they were all saying it was a most retruded position. So when the GPT came, they said it is, the first definition said it is the most retruded relation of mandible. And they were all very critical about it should be an unstrained position. Means if you should not push the mandible back because it is a retruded position. And I think given a degree of separation. Then as it continued, the Stewart said it is rearmost, uppermost, and midpost position. That's a rump position. It was very popular for some time. And then the American Equilibration Society that came up, they said there are so many people are expressing so many comments or so many of their opinions. Why don't we collectively have one opinion? And they said it's a position, it's an anterior and uppermost position of the condyle opposite to the slope of articular eminence. And then Salenza also says it's superiorly and anteriorly against the posterior slope of articular eminence. Okay, so in GPT-3, they slightly modified the definition, the most retruded physiologic position, and at various degrees, but now they also added it occurs around the terminal hinge axis. That's a very important thing, change that was seen at this time. Then after 10 years, the American Equilibration Society again came up with a new understanding. They redefined it as it's the condyle. Now the articular disc was also taken into consideration, and they said it is articulating with the thinnest avascular portion of the disc in the anterior and most superior position. And Ramford then he said it's an anterior uppermost position. So again there is a change. So GPT-5, they said they added up this articular disc in there, and they said it's a thinnest articular avascular portion. So this was the definition that we all are very, very familiar with during our graduation and post-graduation. And then there was again some changes. Then they said, I said it's a midmost uppermost position, then there's a most superior position in the mandibular fossa. So it continued like that. And then GPT-7, when it came, they said to all the things are correct only. So they said all the definitions they have put, you follow whatever you want, because there was no consensus amongst the specialists and the gnatologists and the different other specialists, like other disciplines of dentistry, especially orthodontics. So there was no consensus. So they put all the definitions in there, and they said they added up one more. And here they said it should be determined in patients without any pain or derangement. And they also said if there is a pain and derangement, the centric relation may not be recorded very well. So finally, this is the latest definition. Now again here the disc is out. Okay, so now they are saying it is a maxillomandibular relationship independent of tooth contact, and the condyles articulate in anterior superior position against the posterior slopes of the articular eminence. Okay, but its restriction or its relation to the terminal hinge axis, that's a pure rotatory movement, still remains the same. And they also said it should be unstrained physiologic relationship. So this is the point to begin with, and this is the point to end with. So the quest continues. It's just like they do the space missions and so much of scientific advances only to find where did the human being or the life form came from. So it is more or less it is happening like that. So much of controversy in the centric relations. Well, in the meantime, there's Cecil. He tried to put them together and different opinions from different people as 4 theories. Although this doesn't have much significance in the present days, but it has been as an academic interest. So he said it's a muscle theory where the muscles are guarding they are helping to position the condyles. Then the osteofibers theory, they said the bone-to-bone relation. Then the meniscus theory, they said because people were talking about the thinnest avascular portion, so that is the one that is guiding. Then they said ligamentous theory because the ligaments around the condyle are going to limit the movement of the condyle and coming back to the home position. But all these 4 can be true, and they all will be working together, and all the processes are happening, and individual credit is may not be very suitable. Ultimately, what we want to achieve is that we want the articulator to simulate the movement of the mandible as we transfer it from the patient to the articulator. Okay, so what is the significance of centric relation? We all are very well aware of this, that it is a bone-to-bone relation, and it needs to be reproduced, and so it is a repeatable position, and it is not affected by presence or absence of teeth, because there was confusion between the centric occlusion and the centric relation. So that was the problem that they were facing. And then they finally said, no, it is not related to the presence or absence of the teeth, because it's a condylar position. So we have to relate it only with the condyle. And it's a reference position because the movements start from here and it's related to terminal hinge axis and things like that. Well, let us see some other points related to the centric relation. Now, this study from Shafag, he demonstrated that the centric relation, when we are recording, we have to be aware of the diurnal variations. Because of the circadian cycle, we will have in the morning it may be slightly different, in the evening it may be slightly different, because the fluid content in the joint, as we take rest in the night, the fluids may accumulate in the joint, and then it may be a little inferior position, and then later in the evening, as the condyle keeps moving, the fluid churns out, and there may be very limited fluid in there, and so we can have the more superior position in the evening. So what is the best time to record the centric relation? He said maybe sometime in the evening or noon are the better rather than early mornings. Well, now which muscles are involved in centric relation recording? Because it's an unstrained position, right? So the most of the elevator muscles, we always think about the temporalis muscles and especially the posterior fibers of the temporalis, which are really nearly horizontal. So they are the ones, they're mainly acting for pulling the mandible back to its position, along with the other areas. The masseter muscles and the medial pterygoids also play a role because they are elevator muscles and they are angled forwards. So they try to pull the mandible in a slightly forward position. But at the same time, what we want to achieve is the complete relaxation of the lateral pterygoid muscle is the most important to achieve, because any stimulation to the lateral pterygoids is going to pull the mandible forward and it displaces it from the glenoid fossa. So we need to be very careful in assessing the centric relation. The centric relation and terminal hinge axis, because we observe in the definition, it is said it's an untranslated hinge position. So it is directly related to the hinge axis. So the mandible can move in a true hinge axis only when the condyles are in centric relation position. Only then it can move. So it is very important to have this understanding, because the articulator, when we transfer the terminal hinge axis by means of a face bow, and then when we record the centric relation in the patient's mouth, the putting together on the articulator, then only the articulator can act as or simulate the movements of the mandible and can help for different whatever we want to do in the articulator. Okay, so that is how it will be. And if you use a more complex articulators, probably it would become more complex as well. Now let us try to see a few methods of recording centric relation. Now, centric relation recording, there are so many techniques they have been explained to have the centric relation recording, but actually, according to GPT-9, the centric relation record is just a registration of the relationship of the maxilla to mandible, or we can say mandible to maxilla, when mandible is in centric relation. So establishing the mandible to centric relation is more important, and then locking them together is important as well. So the registration, we can obtain it intraorally or extraorally. So let us try to see this with the dentulous condition. As I said, there are two parts with reference to the centric relation: establishing the centric relation position and then recording those centric relation intraorally. So those are important. Now, when we are looking at the recording of the centric relation, there are three parts. There are static, direct, and functional and graphic. So there are two different types of graphics, intraoral and extraoral. All of you are familiar with. The functional methods of Patterson's, Moyer's, and Nadelhou's, they are not of much significance now because theirs are not followed at all. Now we are using the intraoral check bite records in combination with other techniques to position the mandible. Well, so when we are trying to establish the mandible in centric, as I said, there are two parts. Establishing the mandible in centric is one part, and locking them together is the actual recording. All right, so There's different methods like swallow and close, as Shannon suggested. At the time of swallowing, the mandible goes to the centric. And then the fatigue technique, where they said you ask the patient to open and close for several times, and then the muscles will go fatigue, and then they will relax, and then it will be easy for the patient to guide the mandible to a position. The tongue tip to soft palate, it is also very commonly used. Ask the patient to take the tongue backwards. So with the pull of the geniohyoid or genioglossus muscles, the mandible also get pulled, and then it gets positioned in the most posterior and the superior position. The Dawson technique, the bimanual technique, will also work well, but only thing possible is it might cause a destabilization of the mandibular denture base if the care is not taken. Okay, the centric bearing device, as it is without the tracers, it's just a centric bearing device put in the mouth. So it eliminates all the contacts of the occlusal rims, and then it is free to move anteroposteriorly. Then you can guide the patient to take the mandibular back. And the boost biometer is also another technique that when the patient is biting firm on the biometer, it will be centric relation. That was the concept given by Booth. Now, unguided patient perception is, as we understand that it is the most physiological position. So what is physiologic for the patient is only can be perceived by the patient. So it's easier for the patient to perceive and have the unguided patient position, but patient need to be trained as well. The chin point guidance, place the thumb on the chin and then gently push or give guidance to take the mandible back, was suggested by McCollum. Then relax and close from rest position to occlusion is the most favorite of mine. I mean, I feel if you can get the patient in a relaxed position, have the mandible in rest position, and then from there it is just 2 millimeters to close. So it is with the closure or the like an arc of movement, it's very easy to close from rest position to occlusion. And having the mandible in rest position can be the simplest as just leave the patient alone and it goes to the rest position. After every function, it goes to the rest position. Well, then to put it in those dentulous situations, there are a couple of differences. In patient, it is grouped into two: operator-assisted positioning and then the patient-determined positioning. When it's operator-assisted positioning, there is a Roth power bite. This is the most recent one, wherein you will have a deprogrammer-like device in the mouth. Then I'll use the power of the elevator muscles to position the mandible in centric relation. That is how the Roth power bite works. Then the chin point guidance is place the thumb on the chin and then ask the patient to retrude and then give a gentle push. And the bimanual manipulation by Dawson's is practiced very much, although it has certain difficulties. We'll see it later. And that also works. It is a very popular technique made by Dawson. The patient-determined techniques is retruding the mandible. You ask the patient to retrude. When it is not possible, ask the patient to protrude the maxilla, and sometimes the patient will retrude the mandible. Fatigue technique, we have already understood, the tongue tip and soft palate. Maya monitor is another technique that was described by Jankelson, and he said he put the tens to the masseter and the temporalis, and then have the muscles in relaxation, and then have ask the patient to close. That is very popular when it came up, but they found that there are a lot of studies said that when you put the tense and get the muscles relaxed, it may not be truly centric, and they have found that it is slightly anterior to the actual centric. Now, Gotthard tracing, all the postgraduates will be quite familiar with it. So it can be done in dentulous as well as edentulous conditions. And then the leaf gauge is by the long that was also introduced here. Now, how does this leaf gauge works is there are about 55 sheets. Each sheet is about 100 microns. and you place the sheet in between the anterior teeth and till the posteriors disocclude, and then because it removes all the proprioceptive sensitivity or the proprioceptive information given by the teeth, and then the protective reflex generated or the avoidance reflex that is generated by the muscles because of the inputs by the teeth or the proprioception are eliminated. So the patient can easily take the mandible back and position it in centric. That was the concept here. And the Dawson technique is, again, as I said, it's the most popular technique. And then you really need to work on it, because in the recent survey to a lot of dentists in Britain, they said the Dawson technique is very difficult to learn initially and master it for many clinicians. So they said it is difficult because we have to train the patient. Unless we train the patient cannot have the mandible relaxed. And when you are trying to position the mandible in its centric, the patient tries to resist the movement of the mandible, and having the patient in allowing you to move the mandible is really tough. It takes a lot of training to the patient, as well as it needs a lot of training to the person who is handling it. So that is why they said it is difficult. And they also tried to comment it's not a physiologically relaxed position, because we are trying to position the mandible. Afterwards, the patient may or may not really use that position during the normal functions. That is what they said. Then this Lucia jig that is also put along with the longs, the leaf gauges. They both have more or less the same concept. And here the patient is given, and there it is a leaf gauge you go on adding. Here you make it so that make it like an inclined plane. Ask the patient to bite on it. Because of the inclined plane, the mandible moves backwards, and then it gets positioned in it. The same way, there is a modified deprogrammer where you can make a flat surface here in the anterior region, have the teeth, mandibular teeth coming in contact, and then have the posterior teeth in disocclusion. Here, because it's a flat surface with no interference, there is no locking, so the patient can move freely posterior. This is the same what the Roth power by concept has been given as well. So when they are trying to compare these different techniques, they have compared all these different techniques. There are hundreds of articles we find comparing these different techniques, and then they have found that all the techniques will have some or the differences, but some articles say some particular technique is more dependable and more consistent in reproducibility. Some articles have said the bimanual manipulation is more accurate and more reproducible. Then some said using the Lucia jig is more reproducible. Some said there is just a simple unguided by the patient can also be more reproducible, things like that. However, there is no consensus for which is the best. Well, now as we are moving into the digital era, they have also compared the recording it in analog and then digitalizing it, or directly digitalizing it, and then they have compared what is the difference that is going to be. There they found there is a difference in location of the centric relation. They are all positioned about 0.1 to 0.2, maybe 0.3 millimeters at the most, deviating from the actual position. So,
excuse me, sir. So sorry to interrupt.
Yeah, please.
Sir, could you kindly, sir, try to conclude this thing, sir? Because
is my 40 minutes over?
Yes, sir. Yes, sir.
No, I still have 10 minutes left, because I also put my timer here.
Achha, sir, from the technical team, they were suggesting that 40 minutes is over. So
you can see it.
Yes, sir. Okay, sir.
So do you want me to continue or you want me to stop?
No, sir, you can continue, sir, for another 10 minutes. Sir.
Okay, so it would take only 10 minutes. I have very well planned to 40 minutes.
Yes, thank you, sir.
Okay, thank you as well. Techniques of using this, there is a very small differences, and anterior deprogramming device as advised by Ruth is what is present, what is going on. Okay, so the materials used for bite registration also matters. Now there are so many materials that have been advised to use, and most commonly we are using the polyether and polyvinyl siloxane. But we have to keep these things in mind. The thickness, consistency, flow, setting time, material, all these aspects have to be kept in mind, because otherwise, with all that effort, if we are positioning the mandible, and then if there is a problem in recording it, the whole thing goes in vain. So what's the relevance is the most comfortable position for the condyle, and the brain can find this position consistently, and then the brainstem can generate the pattern. So should we have to treat all patients in Centric? Not really. Only if we are using the reorganized articulation approach, that is the most of the area where we need to record the true Centric and then make it. If we are using the conformative approach, then probably MIP should be fine. So the rest position of the mandible is also related to the centric relation. They said mandible, when it is in a physiologic rest position, the condyle would be close to centric or in centric as well. So although there is no much work is done in this area to locate where the condyle is in the rest position of the mandible, because all of us are worried directly to the centric relation, but less worried about the rest position of the mandible because it is physiological. Okay, so they comparatively both are postural positions and both have the unstrained physiologic position. So there should be some definite relations. So because conventional recording has a lot of issues like recording material, obtaining the condyles and position and all those, now we are moving into digital. So digital has more advantages than the conventional recording. So now we are trying to move towards the digital. Okay, so we can use the Facebook transfer in digital, and we can record the bite registration, and then we can scan it and then adapt both maxilla and mandible on the screen. So this is just a depiction of how it can be done. How it can be done digitally. Are you able to see the video?
Yes, sir.
Yeah, okay. So this is just a 2-minute video. Now they're trying to put the references by the Facebook. So the software takes up the Artex articulator that has been used here. So all the reference claims are being used though. And it is also that they are programming it, and then they can have it to move the mandible accordingly as it is noticed. You record the position of all of them. Once it is done, now it can record now the movement of the mandible. It can also record the angulations of the condyle and anteposterior positioning. All that it can do now. So you can see the movement of the mandible. And as it goes further, it can be done. All that can be fed to the software, and now the teeth can move, the jaws can move on the articulator. You can use different articulators also. There are options to use different articulators, and then you can change the articulator and do the work according to your expertise. Okay, so finally, what all researchers express is whatever the method we are using, it is the practitioner's experience and familiarity with the particular technique is critical, and the clinical precision when recording the centric relation. So it is very important for us to train ourselves with any particular technique. If we master a particular technique, all the techniques will work. As we saw, all the techniques do have some error, but then we have to overcome this. Now, I just have some points that we need to think about. Is it really a bone-to-bone relation? Because the disc is there in between. And this term coined as bone-to-bone relation is when they did the cadaveric studies, or before that, the skull bones are studied. So they said it's a bone-to-bone relation. We are still carrying the same with us to say centric relation, and we say tooth-to-tooth relation, teeth are coming in contact. Bone-to-bone relation, bones are not coming in contact, right? So maybe we have to think on it. And another point is they're saying bimanual technique, the having the chin guidance and all that as technique to record. Now, are they really technique to record, or they are technique to position the mandible in centric? So there need to be a differentiation because when it comes to the teeth in position, they say all these are techniques to record. And when it is an dentulous, they say that is the position that is to record, that is to position the mandible in centric. So maybe it's a time that we have to change certain things to rightly nomenclature these things. Still, there is a lot of scope to study centric relation, because as the most recent survey, systematic review, they said there are only 2 studies which have involved about 100 or more than 100 patients. Otherwise, they're all small studies, and they're putting across. So that is very important. Now, these are some questions being asked during the exams: the point centric or area centric, freedom in centric, power bite or centric, light centric, things like that. Okay, so there is a lot about the centric relation. Every aspect can take a good time, but within the 40 minutes of time given to me, I was able to give you an overview